Evening, everyone. Today is the third episode of Pediatrics Unplugged, the monthly webinar series for promoting academics from Government Medical College, Amritsar. Myself, Dr. Manmeet Kaur Sodhi, Professor and Head, Department of Pediatrics from this esteemed medical college, which is more than 100 years old. Our college has a great legacy and has been the front leader in promoting and bringing up pediatrics as a subject, not only in India, but most of our alumni are the ones who are practicing pediatrics all across the world in different positions. All the authoritative legends, I would say, from pediatrics have come from this medical college, whether they have started AIMS Delhi or PGI Chandigarh and other premier institutes from the north. So today's program is also an expert led program on non pharmacological interventions that can be done in neurodevelopmental disorders. And we have a great speaker, Dr. Prashant, to enlighten us on this topic. And as is the tradition, one of our proud alumni from Government Medical College will be moderating the session. Dr. Gurpreet Singh Chavda, he is presently working as Professor of Pediatrics in Sri Guru Ramdas Institute of Health Sciences, which is a very upcoming and a good academic institute of North India. Dr. Gurpreet Chabra has done his undergraduate, graduation, and post graduation from this institute. I'll be handing over the mic to Dr. Gurpreet to introduce our esteemed speaker for the day. For all the delegates who have joined in, thank you so much. You can put your queries regarding the topic in the question and answer box in the chat box that can be taken up later after the session is over. So, here is to an evening of learning new things. Thank you, everyone. Over to you, Dr. Gurpreet, to introduce the esteemed speaker. Thank you, Dr. Prashant, for being with us.
Thank you. Thank you so much, Dr. Manmeet, and good evening, everyone. Good evening, Dr. Prashant, sir. Nice talking to you. So before starting the proceedings, I would just want just introduce sir's CV. So can I have it on?
I'll share this.
Yes, sir.
Yes, sir.
So Dr. Prashant is a pediatric neurologist. Sir, I lost your.
Yes.
So he's a designated pediatric neurologist, and his current position is he's a teacher, a DNB teacher. So I'm missing the slides. Where is it? So can you go back, sir? Yeah. So current position, he is a DNB teacher. He's directed Utage Child Development Center, Hyderabad, that is in Telangana state, Latur and Nanded in Maharashtra, Bidar in Karnataka. Again, he is a medical director, Umang Institute for Autism and Multidisciplinary Research Center, Latur. And he is also faculty in National Institute for the Empowerment of Persons with Intellectual Disabilities, that is NIEPID. So apart regarding his academic qualifications, after doing his DNB Pediatrics, he has a fellowship in pediatric neurology and epilepsy. And also he has a postgraduate diploma in applied human rights from Osmania University, another diploma in medical law and ethics from Gujarat National Law University. He's an MBA in hospital medicine and again a LLB, a lawyer also. So very nice. Then professional affiliations. Sir is a secretary of Association of Pediatric Neurologists in Telangana state. He is EB member of Association of Child Neurology India. He is an associate member Board of Genetics Telangana Awards. He has been awarded with AOC and award for outstanding contribution in child neurology in the year 2023. He has multiple national and international publications. The highlights is Excel Expert System Journal, March 2023. That was the largest study on autism spectrum disorders using deep neural networks. Sir, kindly start the proceeding.
Thank you, ma'am, and thank you, sir, for a kind introduction. So now this is the most important topic when Madam called me up that we need to talk on a nutrition. So I made a combination of pharmacological treatment because everyone know now there is a paradigmical shift from infections to non-infectious diseases after post-COVID. So what US and UK experienced the peak of neurodevelopmental disorder in 90s. Now India is undergoing that transformation. And obviously, I believe pediatric practice is going to change again next 4 to 5 years. It is more towards the neurodevelopmental disorder. So being a pediatrician, it is very important because you are the first pillar where the patient comes and then that goes to the other team like pediatric neuro and developmental pediatrician. So our objective of this lecture are very clear that to understanding what is actually nutritional and non-pharmacological interventions. And at the same time, we should not be just, it should not be a more of pharma driven. So there should be evidence when we are talking about giving this supplement. At the same time, what practical implication we can do it or adopt during our practice while advising the parents, we need to see. So what is scope of the problem? As you know, the incidence of prevalence and incidence of autism, it was very like 1 in 500 and it has come down to 1 in 100. And now post-COVID, the new survey shows it is 1 in 36. And there are associated comorbidities in autism, especially. So these are the GI symptoms. Then there are suggestion by therapists and other doctors for the some diets, and they may suffer with the severe nutritional deficiency too. So this problem load is high and it's going to be more high. So first I will more focus on a role of rehabilitation professionals in a medical management, non-medical management. So it's more of observation and monitoring. So what are the first the role of medication, as we won't go into details. But if any practitioner start the medication, either pediatric neurologist or developmental pediatrician, they need to monitor is the child is undergoing any side effect of that. Then therapy implementation, their core symptoms need to be identified. And it is a interdisciplinary communication between the doctor and therapy team, and at the same time involving the family too. And why pediatrician is important? Because that is the main pillar stone along with rehab and family and other team members of the rehabilitation. So goal of non-drug ASD treatment is give the quality of life to the kids and at the same time to the parent to address the core development, that is their social support, cognitive, emotional growth, their functional skills to make them independent, and to give the family support. So always, parents ask, sir, are there any side effect? Allopathy medicine का कुछ side effect है क्या? So they are more concerned about the medication. So they want to go about homeopathy and Ayurvedic. So they prefer non-pharmacological approaches. And being a pediatrician, we should be aware what are the things that they are available. So there are many therapies, physical therapies, exercises, nutritional, digital, and elemental. And if you open the Insta or Facebook, there are n number of non-medical doctors who are treating such patients. So we should be aware and address their query. And they are better accepted, as I said, because of that. So what are these non-drug interventions? So it is a behavior therapy, ABA therapy. It's more of a structure approach. We don't go into details of all these things. Second is the speech therapy, occupational therapy, which will address their oromotor sensory issue so that feeding and nutrition should be established. Psychological, so it is more of a emotional regulation and mental health of the child as well as the family. So now I will focus more on early intervention by the non-medication. So it's more of a stimulation. As we are aware, the most critical period of the brain development is 0 to 3 and 3 to 5 it is a more of a learning foundation skills, and after 6, it's more of a early foundation development. So this critical period is very important, being a pediatrician, for us to minimize the deficit if it happens. So we should intervene in the sensitive period where we can, by if there is a developmental delay, autism or speech delay, we can introduce the environmental stimuli, speech therapy, nutritional supplement here, so that before they cross the critical period, we should intervene in a child brain development. And why, how does it work? So neuroplasticity. So how our brain neurons will adopt. So what is important for transmission is the stimulation as well as nutritional support. When we go into the details of every element, we'll go into the detail. So neuroplasticity or brain's adaptation is very important to, like, it's to change the brain structure, functional changes, activity dependent changes, and that too in early ages. So now our aim of early intervention, being a neonatologist and pediatrician, we come across developmental delays. So to prevent that, the delay and disability, screen at risk neonate, preterm, preterm neonate, and then early like infancy, we should be able to pick up. Once we pick them up, give the stimulation so that deficit will be less. And then at the same time, we need to stimulate the family to give this stimuli and to achieve the maximum potential so that we can prevent the disability. Now, this slide is very, very important. Why do we give the speech therapy, occupational therapy, and behavior therapy in a child? Because experience can change the brain structure. So it is activity dependent. Suppose if you fire only one neuron again and again, that's where the autism symptoms appear at 1.5 years, because mother or a parents use the screen. So the again and again connection are activated with the digital screen. So these connections are well developed because they are in activity dependent. So these circuits will develop because the beauty of the brain is if you use the brain again and again, the particular circuit, it gets strengthened. That's where if you see in a child with autism, if you call by name, they doesn't respond, but the same child will respond to a digital frequency. He'll be able to, if he plays we play his favorite rhyme, immediately he will respond. But mother calls by his name, he doesn't respond. Why? Because the experience changes the brain structure. That's where the virtual autism and the repeated use of screen, rhymes, and cartoons, that plays major role in this. And that's how they come across the virtual autistic spectrum disorder, speech delay, nowadays as we are coming across first 3 years of life. So identifying the children for early intervention is very important. So who are they? So at risk infant, as I said, preterm, low birth weight, and tweens, it's more common developmental delay. Medical concerns like neonatal seizures, asphyxia, and sepsis. Developmental warning signs. So red flags, we need to identify it early. I don't go into the details, but sensory issue also we need to find it out. And genetic factors like family history, any genetic syndromes we come across. These are the normal infant reflexes which we should be looking at. But if these reflexes are persistent, that shows that it is abnormal. So persistent reflexes may indicate that there is a developmental concern with that, like startles, morals. If it is persists more than their time limit, then it is abnormal. So we need to work with the early stimulation. Visual stimulation, you find it in autism, there is less eye-to-eye contact. They will be able to see, they have the vision, but the eye-to-eye contact will be less because of the repeated use of visual stimulus. So see, early intervention or stimulation approaches, especially the tactile, vestibular, auditory, and visual. So all 5 senses has to be used in a proper way. This one I don't go much into details, but one slide I want to highlight. What our grandmother used to do it with us is the massage. These are the benefit and what we used to get it. But because of the working parents and nuclear family, the babies are now lacking with this stimulation, that is emotional bonding, physiological benefit by regulating the circulation, digestion, and sensory integration. And it also helps to give the good response to the stress and emotional stimuli. But this is now missing it. And this has been proven with the evidence that early stimulation by these methods, using all techniques, gives good improvement. Now, as we know, brain growth in early childhood is like you can say there are 100 billion neurons at birth, and it's of more of 80% of the adult size. And there are 1,000 trillion connections. So, if you don't utilize these 100 billion neurons and 1,000 trillion connections, they will die out. That is the pruning. So these are the few examples of early intervention with developmental delay. So this first child, you can say little bit syndromic child, hypotonic. She has been giving early stimulation, identified by our pediatrician colleague at Latur. These are the videos from Latur. So they have identified it and referred to our center. But in spite of genetic mutation, with early intervention, this child has got good opportunity because of only early identification by the pediatric colleague. And this child is able to walk after intervention. This is the second slide. This was the NICU graduate. You can see there is a microcephalic, clear cut, and gross motor delay. But with early stimulation, child is doing very good. One more video of the child. This child is very hyperactive, not able to sit at one place, no eye contact, not responding to the command. Same child after intervention by our therapist in the occupational therapy department, able to follow the activities. Child has calmed down, his energy level has come down, he is doing the coordinated activity on his own, and he is very much cooperative. This is the day one in a center, same center, this is after 1 month. One more, this is the NICU graduate, developmental delay, microcephaly, and typical symptoms of hand regard, no eye-to-eye contact, stereotypical movement. But after intervention, same child, you can see now the energy has come down, he is able to concentrate, following the command, and with early stimulation, child is able to walk with support. So same, and this is again, these are the typical cases where pediatrician have identified and send it early. If they come to us directly, they take long time. They may present to us at 7 to 8 years of the age, and they may become the likely candidate of permanent disability. And because of only one early referral, early identification by the pediatric colleague and treated by our complete team, it has given the child the opportunity to go towards normal child. So we need to focus on early intervention because of the maximum impact, because it greatly influences the developmental trajectory. Neuroplasticity, yes, we should take care of maximum utilization of neuroplasticity in a young brain and more adaptable to the changes. And foundation skills should be done. Now I'm moving towards the favorite topic of everyone, and along with our pharmacology colleague too. So what are the common deficiencies? So these are the zinc, omega-3 fatty acids, iron, and vitamin D. We are aware that what are the common nutritional problems we come across. But I'll be highlighting about zinc, that it is very, very important for the neuronal development and immune system regulation. So it affects mainly the sensory part of that taste and taste perception and appetite. Also, it impacts the cognitive. Similar with the iron, is it's proven that it affects the myelination of the neuron, and it's more of a neuronal connections, and it impact the attention, hyperactivity, and learning. Omega-3, it is essential for the brain structure and function. So it's critical for neuronal membrane synthesis and stability of the membrane. It also reduces the inflammatory process in the brain. So it is kind of antioxidant. Vitamin D plays very, very major role in neuroprotective and neuromodulation in inflammation. This is a new theory and gut-brain axis. We used to give the probiotic, prebiotic during our PG days in a pediatric for the diarrhea. But similar kind of now, they have been used in a autism with their gut issue. So it is more of a gut-brain axis. If there is any disturbance in this gut-brain axis, it's directly going to affect the brain function, irritability, hyperactivity in a kid with autism. You see, it's more of a leaky gut and neuroinflammation behavioral manifestation. So we should be aware that yes, if some developmental pediatrician or pediatric neurologist is giving probiotic, prebiotic, it is not for the diarrhea, but it may be to treat his gut-brain axis. We'll go into details in next slides. Now, evidence-based intervention, that is ketogenic diet. Yes, you are aware that ketogenic diet is used. I know it is for us for the losing the weight, but in pediatric, it is more of a epilepsy treatment because refractory epilepsy, this is a kind of diet where we use to reduce the seizure frequency in a comorbid epilepsy, means refractory. It improves the cognition function in some cases and requires strict medical supervision by the medical professionals as well as nutritionists. Mediterranean diet, it is evidence is little bit moderate to high. It's a kind of anti-inflammatory properties, rich in essential nutrients and improve gut microbiome diversity, as I have shown in the previous slide. Then the gluten-free, casein-free. Now, this is the very, very common question asked by the parent. Sir, we went to the therapy center and they're asking to stop each and everything what you are giving, wheat, milk, sweet. So it is a gluten-free and casein-free. But there is mixed evidence. It is not proven that this type of diet will help, but it is a individual base. So you need to be very, because they make mother such obsessive that she should not give wheat, milk, sweet, even tomatoes, some fruits, and child ultimately landed up into the nutritional deficiency. We should be aware, and it is there is no strong evidence for that. It is a mixed kind of evidence. If you see the last 7-year literature review in all national and international journals. Now moving towards the probiotic melatonin, I will go towards next slide one by one. Definitely the role of omega fatty acid to improve the attention concentration, decrease the hyperactivity. Vitamin D3, as I said, reduce stereotypical behavior and many more functions. Zinc, yes, improves the immune function and appetite. Probiotic reduce GI symptoms and improve the behavior, irritability, hyperactivity. Melatonin, it's a kind of antioxidant and it improves the sleep onset and the duration. Now, the one more thing I thought here we will add on the more of a folate deficiency. So it's more of a quadratetrifolic salt. It is a kind of glucosamine salt. So it's a fourth generation folate derivative which required mainly to the bioconversion and most biologically active form of the folate. So it's mainly important for the neurological, where do we get the deficiency of this? So neurological disorders like where there is a mitochondrial diseases, autism and epilepsy, there will be a disruption in a folate utilization. That's where we need to consider this supplement. Then autoimmune mechanisms like production of the autoantibodies that blocks the folate receptors and preventing the folate transport across the blood-brain barrier. Then genetic mutations in MTHFR gene and metabolic disturbances like chronic inflammation and oxidative stress. And this molecule, quadratrifolic acid, is very important for the DNA and RNA methylation. It enhances the process and support the ATP synthesis, and ultimately leads to it's kind of targeted therapy. Rest of the vitamins, as I shared, vitamin D3, A, and vitamin K2, very, very important for the metabolism, especially in a neuronal signaling and transmission. Now, being a pediatrician, how do we screen for such things? So, clinically, we need to have the comprehensive history. So, as with any problem in a pediatric or adult or a medical problem, we need to have the detailed history. And when it comes to diet, we have to see what is the food frequency. There should be some separate individual questionnaires for that. Then mealtime behavior evaluation, sensory food aversions, GI symptoms. How many of you come across that parents come, especially the child with autism, that my child is not accepting the solid food? They're straightforward word. They're just accepting the mother is grinding by the mixer and giving it like a semi-liquid.
Making a paste for
Yeah,
the food.
it's very, very common. So we need to ask it, because if you come across the history by the parent that my child is completely fine, doctor, but he doesn't take the oral solid food, rest of the thing is good. When we go and ask what about the eye to eye contact, no, he gives, but sometimes and sometimes he doesn't give. If you call him by name, yes, he does respond to the everything, but sometimes he may be busy in a game, he may not respond it. So they are tactically just misguiding us when they are giving the history. So we should be very smart enough to get that particular history, especially when it comes to the autism. And second thing, the physical examination, as we are a pediatrician and neonatologist, growth parameters, so height, weight, and for us being a pediatric neuro, head circumference is very, very important. And any abnormal neurological assessment. Then laboratory testing with particularly vitamin D, then thyroid profile, any inflammatory markers if you suspect. And it's more of being a pediatric neuro, we go towards genetic evaluation. Is there is any signs of Down syndrome or any associated symptoms or hypotonia? Is it a central hypotonia, peripheral hypotonia? So we need to go in details and take the help of our genetic colleague. So it's more of a multidisciplinary evaluation by the nutritionist and others also. This home internal nutrition, I don't focus on this because this is in very, very severe cases. But this is very, very important slide for the behavior feeding therapies. So that's where our occupational therapists and speech therapists work on that, or NDT or sensory therapists work on that. So being a pediatrician, we need to guide the mother that positive reinforcement. Don't beat ki nahi kha rahe to bas maro usko. No, it is more of a reward-based approaches for food acceptance. If he eat the fruit, which he usually don't take it, just give him one reward. That may be the one star, that may be the smiley, not the chocolate. Second one is the systemic desensitization. If the child is having oromotor sensitivity, not accepting solid food, so start with semi-solid, increase the consistency, then soft, and then hard consistency. And this, what we require is the more of a parental training. How do you plan according to that? And environmental modification, like as I said, sensory friendly mealtime adaptations, cut down on the screen time, and counsel the parents for the same. Now, special consideration as autism has become rampant. So it's more of a sensory processing problem. As I said, hypersensitivity to particular food textures, their temperature. Some kid may like cold food, some kid may like the hot food. So the sensitivity depends upon that. Then restricted interest, as I said, food selectivities, ritualistic eating patterns. So a very horrible time for the mother when it comes to the meal time. You can't imagine how much pain they have to make the child eat. Then medication intervention. Suppose child is very hyperactive, we start with risperidone, they may eat more. If we start with atomoxetine or methylphenidate, the appetite will come down. So it becomes problematic for the mother. So we need to consider medication interaction and how does it affect the diet up and down. And communication barriers like difficulty in expressing the hunger. These kids, they take the child's hand, like mother's hand, show that you want to eat it. But few kids may not be able, they just start cranking, like just crying, meltdown. If the mother is tuned up with that, she will identify, okay, this is the meal time. So we need to have the more of communication barrier, or sometimes we show the pictures or flashcard to if the child is not communicating. Madam, how much time left with for me?
It's 8:30. We can continue up
35.
to 8:45, no problems.
Yeah.
8:50. 10 minutes we can take any
10.
queries. You have ample time, sir.
Okay. So now these are the micronutrient deficiency in a brain function. As I said, first was the folate, vitamin B12. This is very, very common in a vegetarian population like us. Magnesium supplementation, yes, it plays major role in a tone regulation of the muscles and sleep too. Zinc supplementation, you have seen a lot of importance during the COVID, that it prevent the like very important for the respiratory function. At the same time, it is very important for the brain function too. iron and vitamin D, it's very rampant now. There is an epidemic of vitamin D deficiency. Now I will spend 1 more minute on this gluten-free, cuisine-free diet, very commonly advised by all therapists. But the practice and the evidence is very mixed for this. It has not proven that eliminating the casein and gluten from the diet improves the symptoms. But there are few cases, those who are allergic to gluten or allergic to the casein. So we need to withhold 3 and introduce one by one. If child becomes more hyper, you can counsel the mother, okay, you just trial and error method, and the food which you feel that after giving that child is becoming hyper, cut down on that. Otherwise, parents, when the mother get up in early morning and someone suggests them GFCF diet, she will just have the headache that what to prepare for the child, because wheat is commonly जो हम chapati खाते हैं, फुल्का खाते हैं, that is not paratha, it's not like available for the child to eat. Then what to give it? So we need to see the evidence. So when they come to you and ask that, okay, you can follow, but not that much stick to stop tomato, guava, apple, banana, everything they give very big list. So just mota mota cheese ke, okay, you just identify with which fruit your child is becoming hyper. Just avoid that. Which food you need to identify. It is a tailor-made thing. It is not the blanket therapy that DFCF diet work for complete every autism child. Now, specific carbohydrate diet, yes, there are clinical trials in 2008, like from beginning, but recent trials, when they show that there is moderate evidence that there may be increase in the GI symptoms, but no strong evidence for that. Like because of the IBS in many symptoms, as I said, leaky gut, there are low carbohydrate diet, no sugar, no fat. This is a kind of mixed research. It's not suggesting more of this one. Now, this is interesting topic. How many of you feel that DHA should be given? So let us understand why DHA and how the association of brain development. So omega-3 fatty acids, they are very essential polyunsaturated fatty acids, crucial for brain health, heart health. So it is more for the neurogenesis, synaptogenesis, myelination, and neuroplasticity. As the logic of giving this is Indian population already their intake of fish is very less, so most of them are deficient. That is the logic. Sometimes when you give this DHA, so the evidence like Brain Research Bulletin Volume 174 2021 issue shows that deficiencies of DHA are associated with altered learning and visual functions. So this is also a kind of mixed evidence that high DHA and PUFA supplementation improves the brain function. So high DHA concentration in a breast milk have been associated with several brain-related positive benefit in infant, which you already know. Also, I also know that. So more for the improve hand-eye coordination, memory coordination, and it is the basic foundation for the future learning. And there are many RCTs available with this. We won't go into details, but this is the evidence. As I said, I have just put it in the slide. So omega-3 fatty acid, the mechanism of action is it stabilizes the membrane fluidity, so it enhances the neuronal membrane flexibility. That is the synaptogenesis and receptor function. It's a kind of anti-inflammatory, so neuroinflammation will be less. Neurotransmission, that is modulating the dopamine serotonin signal pathway, that is the neurotransmission, and expression of the genes which like actually regulate the transcription factor involved in a neuronal development. So there is definitely a role of this, but evidence is mixed. It is a moderate evidence. Ketogenic diet, yes, neurodevelopmental disorder, it is very important, especially when it comes to the refractory epilepsy. Now, second most important molecule is the L-carnosine. It has been emerged since last 7 to 8 years, which work as a neuroprotective and antioxidant. No strong evidence, not a very big study, but definitely in few cases, it is individual experience. We cannot put that completely L-carnosine help it, but it is there are cases where we see improvement in this. And where do we get improvements of social recognition? Repetitive behavior will improve. Social smile, eye to eye contact will improve after giving the L-carnosine. In ADHD, definitely there is a role that L-carnosine will bring down the hyperactivity, and it's a kind of psychostimulant drug. And frontostriatal neurotoxicity will be less with it, and more attention and concentration. So these are the references I have put it, the recent references. But there are no like very big studies on this. This is again in a dyslexia. Yes, it has shown improvement, and this is the evidence for the same. Now, gut-brain axis. Yes, we need to go into details. As I said, leaky gut. This is not only for the for the kid with autism, but it is overall for adult also. This has proven that there are a few cases where it proves the good benefit. And like an imbalance in the microbiota and mediated brain gut axis, it increases the more of autism symptoms, hyperactivity, irritability, and this is the evidence. And it shows that lactobacillus bifidobacterium strains have been effective in treating the children with neurodevelopmental disorders such as ASD, ADHD. So this is the reference for that. And there are many references, but mega trials or Indian studies are lacking into this. But definitely the probiotic therapy, prebiotic foods, emerging therapies nowadays are, this is now very fascinating. You may come across within next 1 to 2 years. This has been started in Hyderabad. Evidence we don't know, but these are the early clinical trials that fecal microbiota transplantation. It has started, but evidence is not that much great. Postbiotic supplementation like bacterial metabolite, then like fiber supplementation, phage therapy that is targeted microbiome modulation. These are the fancy things parents may come and ask you. So nutritional approach to the ADHD, obviously we need to identify after giving what food child becomes hyperactive, and the common neutral supplement like iron, zinc supplementation, protein rich breakfast, and omega-3 fatty acid supplementation. So there is a level A evidence in this. Now the food selective management, we need to assess comprehensive evaluation of the feeding pattern. As I have already mentioned, what food they accept and reject the food. What is the sensory profile assessment? Here, our occupational therapist will give us a good input for this sensory profile assessment. Then their mealtime behavior, nutritional adequate evaluation by the nutrition uh, consultant. Their intervention, it should be again along with pediatrician, we have to take help of the oromotor therapist, sensory integration therapist. Then we need to train the parents also, create that type of environment. Systemically, we need to introduce one food by one, and gradual exposure by the positive reinforcement system. Mealtime consistency routine has to be developed, not by using the mobile phone. Then monitoring of the supplement has to be done along with your therapy team. Nutritional support for the epilepsy, as I said, ketogenic diet and modified ketogenic diet. For ketogenic diets, yes, there is a level A evidence, very high evidence that around 50 to 70% seizure reduction in responders. Cognitive improvement will be there, required strict and medical supervision, but if you are starting this. Rest of the diet, I don't much focus on that, but ketogenic diet, yes. Now, nutritional intervention for sleep disorders. As you know, melatonin is the one of the best like antioxidant and natural sedative, you can say. So around 50 to 80% of children with neurodevelopmental disorder have significantly impact on daytime functioning because of the disturbance in the sleep. And the similar happens with the parents. If child is not sleeping, mother and father won't sleep, and the complete family will be awake during the day. So their functioning during the day, irritability overall will be increasing altogether for the family. And as I said, the nutritional management of the medication side effects, CNS stimulant, they cut down on the appetite suppression. So we need to see the high calorie diet for the breakfast before giving the tablet. Then antipsychotic weight gain. So we need to be SSRIs, we need to monitor the weight and according to that, monitoring of his nutrient. Anticonvulsant, we need to see the vitamin D supplementation, calcium and pyridoxine, especially in anticonvulsant. SSRIs, probiotic supplementation and adequate hydration has to be given. Mood stabilizers, adequate hydration and potassium monitoring in few food supplement containing more potassium. Nutritional consideration in genetic syndrome like Down syndrome, Prader-Willi, Rett syndrome. So it's tailor-made to balance the weight. Nutritional support for mitochondrial, yes, coenzyme Q, 100%. It is very important ingredient in a nutritional supplement in a mitochondrial dysfunction. And there is new theories shows that autistic spectrum disorder kids have the mitochondrial dysfunction. L-carnitine, again, one of the most important, and B vitamin is one of the most important supplement in this. So implementing nutritional care plans, we have to have the medical assessment from us, then dietary consultation, family education for this, and monitoring how child is adopting that. So case study, I don't go into this ASD, but practical implementation is structured food diaries. So we need to educate the mother to maintain the food diaries. It's everything is now available online, color food printout. They want to have it, or they can go with the typical like food diaries available in internet. Then there are visual schedules, how to start with breakfast, lunch, what should be there. So this we can help them out, and there are many mobile applications which will give guide us in this. So parent resource, it's more of for the Western world. For us, pediatrician is the main pillar for this. Future direction, as you know, nutrigenomic, microbiome therapeutic, neuroimaging biomarker, digital health integration. So role of AI is increasing. And being sitting at the metro city, we come across all fancy things, starting from FMT to all camel milk. You won't believe the donkey's milk they are selling at 7,000 per liter. And still the few parents believe that giving camel milk also improves, and there is no evidence for the camel milk also, but they may ask you. So ultimately, before ending my slide, so you are the cornerstone and the major pillar for directing the child towards early intervention, towards pediatric neurologist, developmental pediatrician, psychiatrist, and obviously the nutritionist and complete rehab team. So you should be aware of all these nutritional facts. So take away that evidence-based approach should be there. It should not be pharma-driven. It should be evidence-based that, okay, if there is a evidence, if you provide me the medical articles or journals which will support writing your product, definitely we will write that. Multidisciplinary collaboration, as I said, we need a occupational therapist to handle the orosensometer issue along with us. Any individual assessment, systematic monitoring has to be done, and it should be involving family too. So thank you. This is our big team at one of the Umang Center, part of our NGO. Thank you. So I'll end my talk here. So any questions we can take. Thank you.
Thank you so much, sir. Very elaborately discussed. So there are certain questions in the chat box. One of the participants has asked to share the slide again showing the critical period or the sensitive period. Dr. Inder has asked me. So kindly share again the slide showing the critical period.
Yeah, sure, sir.
Dr. Prashant, can you just guide us about the critical period and the sensitive period, like how to go about addressing this to the parents actually?
Ma'am, as I said, no, I'll just display the slides. So I demonstrated with the video because of that only. So now see what is mean by critical period, a sensitive period. It is the extended time frames. Means suppose it is a 0 to 3 year, 0 to 2 year, you have lost it, you are not given any stimulation. But if you start stimulation at 2.5 years, so these are the extended time frames of heightened receptivity. Means there can be a neuronal plasticity still remaining it. and learning more efficient, but still possible if you give optimal time for the environmental stimuli. Critical period, so it's a specific window when learning must occur. If you don't it after that, it's very difficult. So limited to a particular developmental stages and learning impossible beyond this window. So that's where the role of early intervention comes in. So we were talking about these synaptic junctions. And the same slide I will again go here, repeated use of the neurons. So if you don't use these neurons, 100 billion neurons and 1,000 trillion connections, they prunes, means they die down.
So another thing is, so he has asked again that we need to intervene in that sensitive period, basically.
100%. So this sensitive period only we need to intervene. Take the example of autism spectrum disorder. They come to you at 2.5 years. My child was normal till 1.5 years and he started regressing from that. So if you pick it up early, if you stop the screen, if you interact more stimulation by the human beings, obviously this is a sensitive period where this virtual autism can be brought back to normal.
That is the practice, the early identification and early intervention. There's
Yes.
another question, sir, regarding the dose. Dr. Anju Singla has asked dose and duration of therapy of zinc and dose of vitamin D.
See, sir, it is, as I said, if you proven that there is a vitamin D deficiency, there is a fixed protocol. Zinc, it's individual thing. We need to go for the zinc levels and supplement it. But there is no particular period because we have to prove it that, okay, there is a deficiency.
Fine.
But
Any
during
further?
early stages, it is very important for the 0 to
Dr. Prashant, I would like to have some comments upon the other therapies that are available, like sensory integration and all. How much success do patients get in autism where there is the sensory disintegration?
If you take the example of autistic spectrum disorder, for early intervention during 0 to 3 years, the success rate is 70 to 80%. And in virtual, it is almost all 90%. So it's a kind of you can say, part of occupational therapy, sensory integration. They use fancy name like ABA therapy, sensory integration therapy, reflex therapy, so many, but ultimately the base is the occupational therapy, which they use it, the vestibular stimulation and cognition.
So any comments about the ABA, applied behavior analysis, like
It is,
part
there
of
is
behavior therapy?
very high evidence for that to start with ABA. But if you see the ABA therapists trained in India are hardly 80 to 90 people. I'm not telling you 90%, 80 to 90 people who are BCBS certified. And few of them are diploma, few of them they says they are giving ABA, but actual certified ABA therapists are very less, but there is a high evidence for that.
So can you share some lines about how it is being done, like? And I was reading, I was reading in somewhere like it's they say that it's a sort of dehumanizing approach. I read a line, so that's I need your expert comment.
So I'll share my screen. I actually thought of inclusion into this, but being this presentation, I thought, okay, I'll just this one. I'll now stop this and I'll open. So this was the last presentation. I made it for the pediatrician, so which includes actually the role of ABA. It's more of using our reflexes. So after early intervention, it is the early intensive behavior interventions, which have the high intensity approach and designed for specifically for the young children. It's a systematic implementation of behavior principles and it's proven result that gain in IQ, but it is not dehuman approach. So ABA is a gold standard, most validated evidence-based therapy interventions. it's a sequential learning in a break. So they break the complex skill into small tasks, and it is more of a like these are the behavior modification therapy what like they do. So this child was not able to sit. Saksham, sir, blue. So this is a ABA therapist which are like trying to train the child. So these are the part of discrete trial training for them and many more, so pivotal response training, functional communication training. So it's quite deep, but I'll stop here because it's not more of a detail into that.
There are a
So
few
there,
more questions.
yeah. So the what about a neurodivergent, like something is kind of this is a more of a neuro autism and all these are a neurodivergent rather than a typical neurotype that we even. So they say they don't require any treatment without medicines. So any
Neurotypical,
comment?
yeah. So it is, see, sir, anything if you believe, if you see the yum chat or like car score, even there is a mile, don't wait, just start intervening. It's not going to harm, it's going to benefit the child. So waiting, initially revise yum chat, if you see, they doesn't wait for the stimulation. They start it right away from beginning only. So no point in waiting, we should start stimulating.
Thank you, sir. Thank you so much.
There is one more question like Sanjay Goswami is asking, what kind of mobile applications are useful for autism diet management?
There are no particular, ma'am, say daily one new application coming up in, like I was just presenting the role of AI in healthcare today morning. So there are n number, I'll forward it to you, n number of application available. There is no evidence because these are the tech guys, they take the evidence, like data, feed it to the system and that they use it. So not particular any authentic software where app we can put, it's not like.
Okay, Dr. Reena Kurian wants to know what is Sunrise program, RDI program for ASD, or is it any useful?
Ma'am, these are the, as I said, no, everyone is coming up with the reflex therapy, this program and that program. But as the evidence, gold standard evidence is not there. If you see the ABA has the gold standard evidence. So there is no such evidence because what we need being a medical person is to have the evidence base. So it has to be published. There has to be some science behind it. So parent will come and they ask beamer therapy, acha hai ma'am, we'll go it for that hyperbaric oxygen. I wantonly didn't mention it. Stem cell therapy. These are not authentic. Still, people use it in spite of you telling that don't do it. Stem cell therapy, they go and do it. It is under the research. It's not strong evidence to do that.
The big question about autism and hyperactivity, what is the role of sugar? There's so much on the net, on Google available for this, and parents are really confused.
No, I mentioned in GFCF diet, there they add the sugar. There is no proven role that withholding the sugar make the child normal. It is case to case basis. It is not blanket therapy. So we advise the mother, okay, you stop sugar for 1 week, again introduce. If your child is becoming hyper, then stop it. He doesn't have the diabetes. वो इतना strongly follow करते हैं ना मैम sometimes to the therapist वो खाना क्या खाएगा बच्चा they land up with so many nutritional deficiencies. So it should be tailor-made, not the blanket therapy for everything.
तो ऐसा जैसे फैमिली और स्कूल का रोल बहुत ज्यादा है, तो जो जो बच्चा स्कूल जा रहा है उस डू यू हैव एनी गाइडलाइंस? तो जैसे हमारे कोई गाइडलाइंस है कि उसको स्कूल जाने में कैसे हम कर सकते हैं? डू सर्टन स्कूल्स हेल्प इन दैट थिंग, और डू यू हैव टू सेंड द चाइल्ड टू स्पेशल स्कूल्स और नहीं? तो स्कूल का बहुत बड़ा रोल होता है
It's a very major
फैमिली के
role.
बाद.
And, being a human right lawyer, I have to like sometimes go to the school and talk to them that it is a basic human right and it's a right of the child with special need or autism to have the education. So they have to accept it. And now next 5 years, these are the like official guidelines. So they plays major role, but we need to go communicate. So school or a teacher is one of the major team member of
Yes,
the team.
the parents, the teacher has a major role.
Yes.
Thank you so much, sir. Thank you so much.
Thank you, Dr. Prashant. It was actually an exhaustive talk because there's so much going around, on the net, on the Google, and everybody is just putting up their view on it. And really, parents actually don't know. They get so confused because the information is not coming from authentic sources. So they will just put up, ye mat do bacche ko. There are so many centers running, for autism and other disorders, but they are not being run by qualified pediatricians or developmental pediatricians or neuropediatricians. So obviously, the parents actually get too confused where to go about it. So I think many queries of pediatricians is also cleared today, because sometimes there are a lot of pharma companies coming to them and telling them you should write this, you should write that. So unless and until it is evidence based and you have a solid evidence to write that with outcome probabilities, there's no fun of going around and letting the parents waste their money and resources and not, get the final outcome. So we've been very privileged to have you as the speaker. And it was heartening to know that you are a human rights lawyer also, and you may be understanding the ethics and the laws that actually help us manage special children in the best possible way. So we would like to have another talk from you, maybe a few months later, on this topic as well, because
Very important
you
aspect.
also understand that uh, most of these kids are not being included in the society, although inclusion is always there on the slogans and the themes. But actual inclusion is not happening because most people don't know what are their rights and what are the responsibilities of the school or the hospitals or the doctors per se, these special children. So I think looking forward to another session with you shortly on this important topic. And thank you so much. Thank you, moderator Dr. Gurpreet, for holding the session together. Thank you, all the delegates, for sharing your queries. If there are any more queries, you can post them to my number I've shared in the chat box. We can discuss it with Dr. Prashant and get you the answers for your queries. Thank you so much, Kapler, for giving the technical support for the program and holding it together. Thank you so much, everyone. Thank you, Dr. Prashant, once again. Looking forward to listening to you again on an important topic. Thank you, everyone. We'll be closing this session. Over to Mr. Jyoti.
Thank you, ma'am.
Thank you so much.
Thank you, doctor.
Thank
Thank
you.
you,
Please,
Mangesh. Thank you,
thank you.
Dr.
Bye all.
Prashant. Thank you so much.